Hi guys, thank you very much for your patience. Sorry, it's taking me a little bit of time to get here. Let's go through a few Vivas and maybe we start with Drew, if that's okay.
Yep, sure.
Maybe just before we kick off, let me just do a very little brief thing about Vivas again. The Vivas, you're going to be given a clinical stem and then 3 or 4 videos on a screen that you've got control of. We normally ask questions per screen, so it's just 1 minute per screen, doing things like describe your findings or things like that. They'll be given a clinical history for most of them, other than often one of the first 1 or 2 questions is a point or shoot, or we just show you a picture and just say what it is. But otherwise, it's all going to be very clinically relevant. So read the intro closely. The stuff in the echo is going to be related to what's in the intro. Let's go for the money first up. If you see a bad looking left ventricle, let's talk about the left ventricle first. You know, it's often going to be related to the stem, and but have a systematic approach. Keep it quite high level, keep the cadence going. And what I might do sometime next week is I might just do a couple of examples of how I think it should be done with Emma. And I'll maybe get Emma, who is a superstar at doing this kind of stuff. I'll fire some questions at her, and then you can get an idea of what a perfect DDU Viva might look like. And maybe if she's feeling mean, she can put a couple of cases together and get me to do it. And I'll try and show you what I think it should sound like. When you're talking, so Prithvi, and I mean this with all due respect, so when you're talking, be clear and confident, no ers, no ums, and have structure. It's just like the ICU exam. Giving that appearance of confidence is really important. And that means that the cadence is at quite, you know, a decent pace. It's no ers, no ums, no, you know, don't sound unconfident, just go in there. There will be nothing to trick you. There will be 1 or 2 difficult cases, but most of the vast majority of stuff that we're going through, like I'm going to show you, okay? There are normally 7 or 8 questions. 90% of them are going to be TTE or TOE. You will get a general ultrasound question, and that's either going to be on a blood vessel, like so DVT, sometimes artery scans, but mainly venous. It could be lung, it could be gallbladder, it could be renal, it could be a AAA, it could be free fluid. So, you know, fast scan. It's never massively, you know, esoteric stuff. Okay. And I say, be confident, make sure you feel like you belong there. You know, you're a lion, and just, you're talking to colleagues. We're not trying to fail you. We just want to make sure that you know the basics extremely well. All right. Cool. Any questions? Rock and roll. All right, case 1. Here you go, Drew. Point and shoot. So what walls are we looking at in this image?
This is a 2D peristernal long axis without color. You can see the inferior lateral wall and then the apical anterior walls. Pointing out the areas of dysfunction, the basal
Stick with the walls. So which walls are we looking at? What's the wall at the top?
Anterior septal.
Yeah, and then this one down here?
Inferior lateral.
Very nice, perfect. How about this one?
So from here, this is a apical 4-chamber view without color. So the walls, you can see the anterior lateral on the right, the inferior septal on the left.
So we're going to ask you that sometime in the question, and you said it faster than I can figure it out, because I always have to think about this one first, and I have to go from my 2-chamber and work my way back. So yeah, you said that beautifully. You will be asked that in the exam. Make sure you know that you've got it. If you've got to take a little second or 2 to think about it like I do, that is totally fine. Just don't get it wrong. If you get it wrong, massive red flag for examiners, and you know, that's the pass fail right in there. You know, you've just got to get your walls right. Take your time. Make sure you've got a system for remembering it. As I said, mine is always to think of the 2-chamber, and then I work my way back. You seem to do it much faster. Very nice. Okay. How about this one, Drew? Describe your findings. These are all different patients. Describe your findings.
I guess from key features are severe biventricular heart failure with regional wall abnormalities and severe left ventricular dysfunction with severe mitral regurgitation. Moving further into that, you can see that there is essentially the left ventricular dysfunction appears somewhat chronic due to the thinning of the septum. You cannot picture the apex and the anterior lateral wall very well. you can see that the left atrium is dilated. The anterior septum, or sorry, the mitral anterior mitral valve leaflet is not excursion, does not have proper excursion. Going to the MR, you can see a large flow convergence. Vena contracta width isn't measured, but the jet is wide and very close to 50%, probably is 50% of the left atrium. Further assessment with color with Doppler would be adequate. Also, pulse wave through the pulmonary valve or pulmonary vein, looking for flow reversal. Moving on to the right atrium. The right atrium visually appears enlarged as well. The TAPC on the right ventricle does appear reduced, and the radial function of the right ventricle looks reduced. I'd want to measure that of the annular width of the right ventricle, but given the dilatation of the left ventricle,
tell me a little bit more about the mitral regurg. You said you thought it was severe. What do you think the cause of it is?
Likely source of the mitral regurgitation would probably be primary, secondary to a regional wall motion abnormality.
And what does that cause? Why is it? So is that
the anterior mitral leaflet would connect through the chordae tendineae and the pap muscle on the lateral wall, anterior lateral wall. And so a regional wall motion abnormality may cause tethering.
Fantastic.
And
so secondary to tethering.
Yes.
Beautiful. So we can see an eccentric looking MR jet here. Can you tell me how you're going to assess it for the severity of that? What other?
What other parameters?
Just tell me about the severity of mitral regurg. You said it was severe. You said it's secondary to tethering of the posterior leaflet because of the regional wall motion abnormalities, leading to secondary MR. And so now we've got an eccentric looking jet. And so you talked a little bit about severity assessment. You said you want to see the pulmonary veins. Can you tell me other views you'd like to tell me about the severity of this mitral regurg?
The other views, I guess I'd want to take a look at the 2-chamber view and the apical 3-chamber view, also the parasternal long axis. I'm not sure what other. Sorry, I'm not following the question.
No, you're all good. So this is really good for Prithvi. This will be a really important question. So I'll take you off the hotspot. Drew, great job. It's a really nice start. What we've got to do with the Viva is you've got to be able to answer what you said there in a bit of a shorter period of time. So you've got about a minute to go through both of these questions, and good to have that systematic approach. And again, just try and get through it just a little bit faster. And then with the mitral regurg, you're absolutely right. This is clearly severe MR. But what you need to try and get through in about, give it like a minute, you've got to be able to give a very, very quick overview of how you'd assess the mitral regurg. So it might go a little bit something like this. You'd say, if this appears to be severe mitral regurgitation from what I can see in this, I'm guessing that severe regurgitation is secondary to tethering because of the regional wall motion abnormalities on the right side, and that's tethering of the posterior mitral valve leaflet, hence the eccentric looking jet. The problem with eccentric jets is that some of the routine methods that we've got of assessing MR are going to be difficult because we have the Coanda effect, Coanda effect, where the kinetic energy is taken over because some of the energy is hugging that jet to the wall. So I have to look at things in order. I'll start off with continuous wave Doppler. I'll try and be off-axis imaging, continuous wave Doppler in line with the angle of the jet in my color wave Doppler. And I'm going to look for the density of that regurgitation jet. And I'm going to look with color Doppler also at the vena contracta. And I'm going to try and make sure if it's severe, it might be greater than 0.6. Next, I'll think about pulse wave Doppler, trying to assess as many pulmonary veins as I can. I'm looking for systolic flow reversal, indicating severe mitral regurg. I might not get it because of the eccentric nature of this jet. Finally, with pulse wave Doppler, I'll look at the E wave velocity coming through. And if it's greater than 1.4, in some of the literature, they suggest that's associated with severe regurgitation. Finally, I'm going to put that all together and try and look at the clinical state of this patient. This patient's obviously got raised left atrial pressure, and we'll see if that fits in with the stem. Yeah. So just nice, quick, broad brush strokes going through 2D, multiple views. Can you explain the severity? Do we have an obvious problem? Continuous wave Doppler, color Doppler, pulse wave Doppler, and then stop talking. Yeah. So just try and do that for mitral regurg, mitral stenosis, aortic regurg, and tricuspid regurg, and just have that kind of structure and that banter ready to go in a nice systematic manner. That makes you sound, you're probably not saying too much, to be honest, but it's just trying to make sure you've got that in a nice, clear manner. And I guess it's a bit like the part 2 exam, the hot cases, right? You're trying to say something like saying, how are you going to wean this patient from mechanical ventilation or something? And you'll put that quite complex question into a 1-minute answer. Yeah. Sprinkled with a bit of Prithvi magic. Nice. All right. Prithvi, let's have a go at this and then we'll do it. So which of the following is true regarding acute papillary muscle rupture from a myocardial infarction? So 1, the anterolateral papillary muscle is most likely affected. 2, the acute MR flow is in the opposite direction of the area affected by ischemia. Right coronary artery occlusion is the most likely culprit coronary artery. It is a relatively benign complication from a myocardial infarction.
I think the true statement is number 3, RC occlusion, likely culprit coronary artery, because the posteromedial papillary muscle is the commonly involved, which is supplied by the right coronary artery.
Beautiful. It can be supplied by the left, right as well. So the circumflex, most likely it's the right. Very nice. What about the acute MR flow? So if you had a pap muscle that's ruptured, is it going to be in the opposite direction or the same direction? So I'm going to have to think about this. So if you're doing that area is ischemic, and then you pop it, it's going to go down like that, which should be in the opposite area. Oh, I got that wrong. The opposite area affected by the ischemia. There's benign complication. Have I written that question wrong? The acute MR flow is in the area. I think I've written that question wrong, haven't I? Sorry, I can't move my cursor now. I can't see it. Area affected by ischemia. Yeah, I think acute pap muscle rupture. I've probably got my 2 things mixed up the wrong way there. Sorry, can you see my screen? Have I just messed it up? There we go. So yeah, if you've got a pap muscle rupture from ischemia, you're going to have it going obviously in the opposite direction. Like that. It goes in the opposite direction. If you've got ischemia tethering, I think is probably, I got my question wrong. Tethering, it's going to go in the same direction like you saw in the first question. Yeah, nice. Sorry about that. All right. Prithvi, do you want to have a go at this? Case 2.
Yeah.
I'll just try and make this all big for you. I do that. Case 2. Met call for hypotension pre-angiogram, investigation for a likely non-STEMI, presented after a fall, diarrhea for 2 weeks, blah, blah, blah. None of that's interesting. Became acutely hypotensive in the cath lab whilst waiting in angio, 3 days after a non-STEMI. Describe your findings.
Right. So parasternal long axis view with the anteroseptal and infralateral walls. It's got a bit of depth, so I can see a little bit of the far side lung. The left ventricular systolic function is impaired. The infralateral wall seems to be hypokinetic on this view. The mitral valve is abnormal, and the coaptation seems to be quite abnormal. There seems to be some structure flicking in and out around the mitral valve, possibly a ruptured chordae or a ruptured pap muscle, because it's 3 days post an MI and she's gotten acutely hypotensive. The left atrium looks slightly dilated. I would like to zoom in on the mitral valve and slow it down so that I can see that better. There doesn't seem to be an evidence of a large pericardial effusion. The right ventricle seems to be contracting okay.
Okay. So let's get some of the terminology tighter. So some of the things that you said is that the infralateral wall is down or it's hypokinetic. Give me segments, remember, 16 segment model. You can see the basal and the mid. You can't see the rest of it. So say the basal and the mid, you know, infralateral wall appears hypokinetic. And that's associated with tethering of that posterior mitral valve leaflet and then you said it was, I can't remember what you said. It was like there is a structure that's flicking around. Again, give me tight descriptions. You know, what we can see at the moment is it looks like a linear, echo-dense, irregular structure flicking in and out of the LVOT that appears to be attached maybe to the posterior mitral valve leaflet. Given the regional wall motion abnormality in the history, that could be a papillary muscle. Don't give all the things away. You know, it could be, possibly, need to see more views, all that kind of stuff. The LV is down. You know, the LV appears mildly impaired, moderately, or severely impaired. No mild to moderate, moderate to severe. Call it if you see it. Obviously, you need other views. Okay. Nice structure going through it. Again, just pick up the cadence, get through it a bit faster. But yeah, go for the money first of all, and really nice pickup on the clinical stuff of putting that piece together. Beautiful. What do you see here?
So color Doppler applied across the mitral valve shows an eccentric mitral regurg. It seems to be directed posteriorly. And it is likely severe in this context, severe MR. It's got a reasonable flow convergence and seems to have, I have to slow it down, but seems to have flow convergence and a large vena contracta, but I'll have to slow down the views as I can see.
Right. Tell me, what other views do you want? You think that's severe? What else are you going to need to tell you that if it's severe or not?
So I'm going to need to look at other views. So like my apical four chamber to see, and then I'll have to use Doppler, my continuous wave Doppler and pulse wave Doppler interrogation. I'm going to have to look at the, see what my left atrial pressure is. Like, let's look at the interatrial septum. And I'm going to need pulse wave Doppler to look at the systolic, if there's any systolic flow reversal in the pulmonary veins.
Nice. What about color Doppler?
So in color, I'm going to see if my regurg fills more than 50% of the left atrium, but this is difficult in an regurg in an eccentric jet. So that's going to be a limitation.
Because why?
Because of the Coanda effect, the regurgent jet hugs the atrial wall, so it's difficult to assess if it fills the left atrium.
Have a go at practicing that again and again. You know, you got the structure in there, the 2D color, continuous wave, yes, pulse wave, but just try to get through it a bit faster. No ers, no ums, and just maybe it's worth having a sort of a look how I was doing it, how you were doing it. It's bloody awful watching yourself on video, but it's really important for trying to get the hang of that. Yeah, okay, cool. Let's carry on flicking through this. So I'll just sort of the rest of the case, you've got this. I mean, obviously there's a regional wall motion abnormality in here and a structure flicking in and out. So which you talked about the papillary muscle rupture. We've got regional wall motion abnormalities, particularly the inferior area here. Which papillary muscle do you think's been affected?
Probably the posteromedial papillary muscle.
Excellent. So can you tell me about the papillary muscle apparatus? So how does the apparatus of the posterior medial papillary muscle affect each of the anterior and posterior mitral valves? Because which one appears affected in this?
It looks as if the anterior mitral leaflet is affected.
Very nice. And if you had to say which scallop it was, we've got 3 scallops on the anterior.
Yeah, it looks more like probably the A2.
Mm-hmm. Good call.
Because the central part seems to be sort of
great. So tell me about the anatomy of the papillary muscle, and particularly the chordae that are coming off the papillary muscle in mitral valve anatomy.
So I think the anteromedial papillary muscle gives chordate to the anterior mitral leaflet, but also to the posterior leaflet. And the posteromedial papillary muscle chordate predominantly to the posterior leaflet.
Why is the anterior one out here?
So I think got the other way around. I think the posterior medial supplies has struck to the anterior mitral leaflet, and that's probably why with the PML rupture there's A2 is affected.
Really nice. So again, it's a really beautiful example. This is why I was there, showing that the papillary muscles provide chordate to both anterior and posterior leaflets. I agree the posterior one does more, but I think they both do. From the anatomy that I've looked at, I know there are some people who say that it only does it on the other side, but only does the anterior with the anterolateral, but I don't know, the anatomy that I've looked at, there's chordate going from both papillary muscles to both leaflets. Okay. So that's why the anterior has been affected by the posterior lateral papillary muscle. Nice. So which way do you expect the regurgitation to go? So what's the cause of the regurgitation? Which way is it going to go?
The posterior mitral leaflet seems to be tethered and not moving very well, and the anterior mitral leaflet has probably got excess mobility.
Give me a bit more. What do you mean by excess mobility?
It seems to be prolapsing.
Excellent.
Or probably even a bit of flail, but flail is probably not flail because the tip is not really
Yes.
pointing towards the left atrium.
How do you differentiate prolapse from flail?
So prolapse, the tip usually is concave and it faces the left ventricle, whereas in flail it's free flowing and it is points towards the left atrium.
Nice. So this one is prolapsing, and I guess the other definition of prolapse is where
it goes beyond the coaptation border.
Perfect. Good words. Coaptation border, prolapse, flail, apex pointing towards the apex, down, back. Beautiful. Which way do you expect the regurg to be?
Prolapse, it would be the same side as a lesion, whereas flail would be the opposite direction, usually.
Sure about that? Because again, this guy's got tethering, remember. So prolapses can go the other way as well, as you can see here from the tethering.
Yep. Yep.
Really nice case. What are we looking at here? And tell me what's label things for me. It's a bit hard when you don't have the cursor.
Yeah, I think the earlier image was a color Doppler across the mitral valve showing a severe eccentric MR, which was posteriorly directed. It seemed to be with the Cohen effect going along the left atrial wall and probably reaching the posterior part of the left atrium and possibly entering the pulmonary veins. And this one is a pulse wave Doppler in the pulmonary vein, which is showing features of pulmonary systolic flow reversal. I can see the direction of flow. Yeah.
Nice, I'll take that. What about this one?
This is a pulse wave Doppler on the mitral inflow showing the E and the A waves. It gives me an E velocity of just over 1 meter per second. Normally, for a severe MR, your E velocity should be more than 1.2 or 1.4. But I guess this is because this is an eccentric jet and it is not a central mitral regurg. This may be underestimated.
Very nice. Very, very nice indeed. Yeah, great job, man. All right. Drew, do you want to have a crack at this one? This one's a little harder, to be honest. Okay, so we've got a 60-year-old female, unwell with fevers, rigors, and a new loin pain with pyelonephritis. There's hemodynamic collapse with rapidly escalated catecholamine requirements, background hypertension, and AF. Before we go any further, tell me what you think I'm going to show you.
Well, I saw the first picture, so I think it's a systolic anterior motion of the mitral valve. But
yes, sweet. So if anyone's telling you rapidly escalating catecholamine requirements, just think that. What else could it be?
Look, it could be an endocarditis. It could be a systolic, like catastrophic valve lesion. It could be a cardiomyopathy, a septic cardiomyopathy, a Takotsubo with the LVOT obstruction.
That with the rapid, for me, the rapid thing though is important. You know, that's septic cardiomyopathies. They don't go up like a bloody in minutes. That's so it's a subacute process. So I get the endocarditis if you suddenly like lose a valve, if
Yeah.
it's a pap muscle rupture, or it's you know, some kind of acute tamponade, or you know, it's going to be you know, dissection. It's going to be something bang, you know,
Quite
it's
acute.
suddenly rapid escalation, or it's so it's basically obstruction or a valve just suddenly just going. So no, so if it's a rapidly escalating thing, something sudden, something's broken, something like that. Yeah, good job. So excellent. You saw the first picture, which means that you know echo. If you can just see that quickly as I saw it, I showed this to you, and then suddenly you got it. You know echo very well. So tell me, you told me you thought this was
systolic anterior motion of the mitral valve with a left ventricular outflow obstruction.
Beautiful.
And
yeah, nice.
Yeah, and the rationale for that, if you look at the picture of the 2D, she's got a increased wall thickness. She's got a dilated left atrium. If you then look at the M mode, you can see that anterior mitral valve leaflet is getting pulled towards the septum during systole.
Excellent. When's systole on the ECG? Sorry, asking stupid questions just for everyone in the audience.
So it started the QRS to the end of the T wave.
Beautiful. So we've got a normal appearance sitting there during diastole with the anterior and the posterior mitral valve leaflets opening up. Sometimes you get an E and an A wave. We're not really seeing that. But you can also see the cavity is quite small. We can see the ventricle appears quite thick. It is thickening during systole and diastole, so no obvious regional wall motion abnormalities. But then during systole, you see this weird movement. That's the weird bit, right? The anterior mitral valve leaflet is being pulled during systole towards the anteroseptal wall.
Yep.
Nicely done. Fantastic. So here again, you can see that horrible hypertrophy, and there's the systolic anterior motion of that anterior mitral valve leaflet. I'm really sorry, I'm on for the private. I'm going to have to answer this. Excuse me. Hi, Samuel speaking. Sorry, excuse me. Yeah, the tip and the trick just for looking at this for me is don't look at the valve, look at the ventricles. So you put your eye in the middle of the ventricles, and as they come together, use your peripheral vision to see if there's anything being pulled into the LVOT. It's the best way. All right, so right, Drew, how are you going to tell the difference between LVOT obstruction versus MR? Because often when you get the anterior mitral leaflet being pulled in, you get some eccentric MR.
Yeah.
Classically, that's anterior, but it can be posterior, particularly in the critically ill. But how do you differentiate LVOT from MR? Because you're going to get this eccentric weird jet.
Yeah. I think with the LVOT obstruction, you'll get more of a saber type appearance, a gradual peak. I think it's also in MR, it tends to be pansystolic in nature. And I guess as you move your PW cursor, there'll be a change in the velocity as well. Perhaps an augmentation with Valsalva. That's all I got.
Interesting, nice. So you got it right. So first of all, it's the Doppler profile. You got that saber tooth profile for the LVOT obstruction, and then it's down to timing. So you didn't mention the peak velocity. You can have LVOT velocities that are greater than the MR. So it's not about that, it's about timing. And so particularly if you look on this right image, you've got the later peaking jet is the LVOT obstruction. And you can see the MR has a greater broad-based jet because it doesn't have isovolumetric relaxation and contraction. So the LVOT is slightly narrower because it has isovolumetric contraction and relaxation. MR is more broad-based. So that's how you try and tell the difference between, you can just see it on that first one in B, just above B, and that profile is probably the best that you can see. The LVOT obstruction looks like it's just a little bit narrower at the top than the mitral regurg, I reckon.
So it's at the top of the peak of the jet. It tends to be sharper.
So yeah,
with LVOT.
Yeah, absolutely. So as you said, I think you said it was pan-systolic, which is a really nice way of doing it. So MR is pan-systolic, whereas the LVOT obstruction has isovolumetric contraction and relaxation, so a little bit smaller. You just got to open up the aortic valve, right? You need to generate some pressure before the aortic valve opens up.
Yeah.
Good job.
Thank you.
We might make this the last one if that's okay. So Prithvi, let's go back to you. So you've got a 55-year-old man, history of shortness of breath, paroxysmal nocturnal dyspnea with lower limb swelling with a history of hypertension.
Wow. Okay. So I can see an apical four-chamber view. The most prominent feature is a severely dilated right ventricle and a severely dilated right atrium. This is likely to be a chronic process because I can see prominent trabeculae in the right ventricular apex, suggesting increased right-sided pressures for a prolonged period of time. The right atrium is severely enlarged, and the tricuspid valve is not even coapting, and there is likely to be a free central TR in this case on color Doppler. The left ventricular contraction seems reasonable, but there is severe interventricular septal flattening on the left ventricle, suggestive of.
That's fine. So what view is this and what does it show?
This is the RV inflow view, showing the right atrium and the right ventricle, and the color Doppler across the tricuspid valve shows a severe free TR.
Excellent. So what's this?
And there is color going back into the inferior vena cava.
Very nice. Inferior vena cava. What's this top one? What's coming from there?
Coronary sinus.
Very good. Okay, so this is the severe TR jet, you called it. This is the continuous wave Doppler through there. Can you describe your findings?
Again, looking at the top view, the Doppler alignment is not exactly parallel. It's a little bit off axis, but with what I can see, the tricuspid regurgitation profile seems to be quite severe. It is a dense jet, and it has got a very sharp profile, suggesting and a quick taper, suggesting rapid equalization of pressures.
Beautiful. Beautiful. Yeah, well picked up. What do these images show?
And this is color Doppler and pulse wave Doppler across the hepatic vein, which is showing evidence of hepatic vein systolic flow reversal in the hepatic veins, which is again suggestive of severe tricuspid regurgitation.
Very nicely done. That was excellent. Excellent. All right, guys, again, apologies for being a little bit late today. I probably better call it quits at that. I'm being pulled in a few different directions. Thank you very much indeed. We'll get these up, and just recommend just going back and let's have a listen to some of these things, particularly that MR, and just work on, just that systematic approach to that question of how would you approach these different severe valve lesions. Okay.
Yep.
Thank you all very, very much indeed for attending.
Thanks, Sam.
Thanks, Sam. Appreciate it.
Bye. Thank you very much.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And Thanks for watching.